Welcome to OAC Health Talks. I'm Joe Naglowski, President and CEO of the Obesity Action Coalition, and we are excited for you to join us for this educational series that dives deeper into specific health topics that we know are important to you and the OAC community. Health Talks are designed to empower you while providing straightforward, practical answers and insight from trusted experts. So let's dive into today's topic.
Hello, everyone. My name is Priya Jaisinghan, and I am a triple board certified physician in internal medicine, endocrinology, and obesity medicine. Oftentimes in clinic, I'm asked about Polycystic Ovarian Syndrome, or PCOS, and its relationship with obesity and excess weight. So I'd like to take some time to go over what PCOS is, what we know about the pathophysiology, and how it relates to living with obesity or overweight. So let's begin. So why is this important to speak about? Well, PCOS, or Polycystic Ovarian Syndrome, is the most common endocrinopathy affecting reproductive aged women. And the prevalence of PCOS is 10 to 13% globally. And what is PCOS? So while there are several definitions of PCOS, we are going to review the most widely used criteria called the Rotterdam criteria, a recent update to the criteria based on the 2023 International Evidence-Based Guidelines for Assessment and Management of PCOS, and then we will review what contributes to weight gain in PCOS and touch upon some of the associated conditions and review some of the treatment modalities. So let's take a look at the Rotterdam diagnostic criteria for PCOS first. So the Rotterdam diagnostic criteria for PCOS requires at least 2 of 3 criteria for diagnosis. One of these is ovulatory dysfunction, the second is hyperandrogenism, and the third is polycystic ovarian morphology. So let's go through each one of these. So ovulatory dysfunction may manifest as menstrual cycles less than 21 days or greater than 35 days, or less than 8 cycles per year. And this is from 3 years post-menarche to menopause. So 3 years after you get your period to perimenopause, this definition can be applicable. So, however, it should be noted that individuals that have ovulatory dysfunction can still have regular menstrual cycles. So 15 to 40% of females with hyperandrogenism and regular menses can have ovulatory dysfunction. So when irregular menstrual cycles are present, a diagnosis of PCOS should be considered and assessed, and that's according to the PCOS guidelines that we have currently. So moving on to the second criteria, hyperandrogenism or excess amount of androgens. So hyperandrogenism can be clinical, biochemical, or both. And clinically, hyperandrogenism can be characterized by hirsutism, androgenic alopecia, acne. So hirsutism is excessive terminal hair that appears in a male-like pattern or distribution. So for example, over the chest, midline lower abdomen, above the lip. And there's also biochemical hyperandrogenism, and this can be detected on blood work. And this usually shows up as an increased testosterone level. So if a testosterone level, a total testosterone or a free testosterone level is not elevated, you can also consider measuring other things such as androstenedione and DHEAS. The third criteria is polycystic ovarian morphology, or PCOM, on ultrasound. So PCOM criteria can be based off of a few things. One is follicle number per ovary. The second is follicle number per cross-section and or ovarian volume. So according to the 2023 International Evidence-Based Guidelines for Assessment and Management of PCOS, we can also use serum anti-Müllerian hormone, or AMH, could be used for defining PCOM in adults alternately instead of using ultrasound. Okay, so what is serum AMH? So in people assigned female at birth, cells inside the follicles of the ovaries produce AMH. And follicles are tiny fluid-filled sacs in the ovary that contain and release eggs. So AMH levels correspond to the number of eggs you have or your ovarian reserve. So generally speaking, a higher AMH level means more eggs and a higher ovarian reserve, and a lower AMH level means fewer eggs and a lower ovarian reserve. So serum AMH should only be used in accordance with the diagnostic algorithm, noting that in patients with irregular menstrual cycles and hyperandrogenism, an AMH level is not necessary for the diagnosis of PCOS. In patients with irregular menstrual cycles and hyperandrogenism, an ovarian ultrasound or AMH is not necessary for a PCOS diagnosis. Remember, only 2 out of 3 criteria are needed for the diagnosis. Along with this, disorders that mimic PCOS must be excluded, such as non-classical congenital adrenal hyperplasia, hyperprolactinemia, and thyroid disease. So now that we've talked about the diagnosis of PCOS, what causes PCOS and the weight gain which is associated? So the pathophysiology of PCOS is not completely understood. We do know that it's associated with dysmetabolic features that are mediated primarily through insulin resistance. So it is currently estimated that 50 to 70% of women living with PCOS are also living with obesity. So what contributes to obesity in the setting of PCOS? So data suggests that there's a central role of insulin resistance and epidemiology and genetics. So insulin resistance affects about 50 to 90% of women with PCOS. So what is insulin resistance? Insulin resistance can be broadly defined as a subnormal biological response to normal insulin concentrations. So insulin is a hormone that is produced by the pancreas and helps regulate blood sugar levels. So when blood sugar levels rise after eating, for instance, cells in the pancreas produce insulin to help the body use glucose for energy. So remember, we said insulin resistance is when there is a subnormal response to a normal level of insulin. So then the pancreas produces more insulin to try to maintain normal glucose levels, and it leads to hyperinsulinemia, or more insulin. So when blood glucose levels are not able to be completely controlled with even increased amounts of insulin, then the person can potentially develop prediabetes. So remember, insulin resistance can occur in individuals with normal weight or living with overweight, as well as those living with obesity. However, living with overweight or obesity can contribute to insulin resistance. So insulin resistance most commonly occurs in association with obesity, but can result from other underlying causes. So PCOS is linked to other conditions linked with insulin resistance and metabolic syndromes, such as OSA or obstructive sleep apnea, MASH, formerly known as fatty liver disease, dyslipidemia, central adiposity. So these are some of the conditions that we can see. Amongst women with PCOS, 30 to 35% have an impaired fasting blood sugar. 10% have type 2 diabetes. 70% have dyslipidemia or abnormalities in their cholesterol. And 5 to 10 full people with PCOS have an increased risk for development of obstructive sleep apnea. And the prevalence of metabolic syndrome varies between 34 to about 46%. So what are some of the clinical manifestations that we can see of insulin resistance? we spoke about the changes in glucose levels leading to impaired glucose tolerance and potentially diabetes. Other manifestations can include acanthosis nigricans, or velvety darkening of creases of skin, particularly in the back of the neck, the armpit or axilla region, the groin. Individuals can also develop skin tags, have alopecia, experience hirsutism. Some individuals may also experience infertility, high cholesterol levels, specifically high triglycerides, or experience muscle cramps. So now that we've discussed the relationship between insulin resistance, obesity, and PCOS, what do we know about PCOS, obesity, genetics, and epidemiology? So we know that PCOS is heritable, right? There are also studies that some of the heritability is through effects of gene variants that are associated with increased fat mass and inclination towards weight gain and obesity. So one such gene is FTO. FTO stands for fat mass and obesity associated. Okay, so in one study, one variant within the FTO gene was associated with an increased risk of development of PCOS, and in another study, a different variant was shown to be associated with the development of PCOS amongst a cohort of women with obesity or metabolic syndrome. So this shows that there is a complexity of variants in genes influencing not only fat mass, but obesity-related conditions like PCOS. So what should you do if you're concerned about weight gain in the setting of PCOS? You should seek help. So you should absolutely speak to a doctor and one that you trust. So it can be understandable that many individuals living with overweight and obesity may have experienced weight stigma and have suffered negative biopsychosocial impacts. And it's also important to recognize when discussing weight with a healthcare professional that weight stigma is also pervasive in the medical care setting. So you need to find yourself an advocate, especially a weight management advocate. And that may be an individual such as an endocrinologist or a obesity medicine board certified doctor. So goals of PCOS and weight management are going to include formulating small, gradual, tailored changes that are realistic and sustainable in the long term. So healthy lifestyle and optimal weight management should be focused on creating structured treatment modalities, and that can really range from behavioral treatment options, medical treatment options, surgical treatment options, or a combination of those. And weight management in individuals living with PCOS can help restore ovulatory cycles, can lower blood androgen levels, and improve metabolic risk. And we even see sometimes reversal and improvement of associated conditions. So even modest weight loss, such as 5 to 10% of reduction in body weight, can really help. And remember that we're recommending about 5 to 10% to see a reduction in or a reversal in some of these conditions. But remember that weight loss is heterogeneous and the effects could also be variable. So knowing how some of the features or associations of PCOS relate to metabolic health is important to know in order to seek different therapeutic avenues which are going to be helpful. So it's important to keep in mind and to be aware that certain features of PCOS may have a negative impact on one's body image. So eating disorders and disordered eating should be considered regardless of weight, but especially in the context of weight management. So women with PCOS also have higher rates of depression and anxiety compared to women with a similar BMI that are living without PCOS. So if you're personally struggling with eating habits, even things such as emotional eating, stress eating, anxiety, depression, or body image, you should speak to your doctor about a referral to psychiatry. Another association with PCOS is obstructive sleep apnea, or OSA. So OSA also has an association with insulin resistance, with glucose tolerance, and with type 2 diabetes. So if you have poor quality or quantity of sleep, snoring, difficulty breathing at night, you should speak to your doctor. You may need to be evaluated and referred to a sleep medicine specialist. Another association with PCOS is prediabetes and type 2 diabetes. So it's important to speak to your doctor about seeing a diabetes educator, a nutritionist, and talking about medication options which may help with insulin sensitization and weight management. So let's talk about different treatments which should be considered for weight management. So let's start with talking about some of the lifestyle changes. So lifestyle intervention should be recommended for all individuals with PCOS for improving your metabolic health. And lifestyle interventions could include exercise, dietary changes, and behavioral strategies. So there is no good evidence that one type of diet is superior to another for patients living with PCOS. So dietary intervention should always be tailored to you as an individual. And it's extremely important to have a nutritionist on board as a part of that team. It's also very important to address barriers and to acknowledge them and see if we can find any potential solutions to those barriers. And some barriers can include psychological factors, physical limitations, sociocultural factors, socioeconomic factors, but it's very important to acknowledge and address the barriers as best as possible, and that's going to help you engage and adhere to any goals you set, right? Whether that be dietary, lifestyle, any of them. So we've covered now setting SMART goals, associated conditions that you could use in the setting of referrals. Next thing we're going to talk about is exercise. So exercise is also another cornerstone of lifestyle changes. So for many, this can be daunting, right? But remember, some physical activity is better than none. There are no large randomized trials of exercise-specific interventions in PCOS. However, a systemic review of exercise therapy in PCOS did note that there may be, modest weight loss, insulin sensitivity, and improvement in ovulation through exercise. So it's important to remember a few basic tenets. So you can start with small goals, right? So limiting, for example, the amount of time spent being sedentary by replacing sedentary time with any amount of physical activity is a plus, okay? There's also goals that we can talk about for prevention of weight gain and just maintaining health. So adults should aim for a minimum of at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity aerobic activity per week, or in combination of both, right? Spread throughout a week. And this can also include muscle strengthening activities, so either resistance or flexibility. And this should generally be tried to be done on 2 non-consecutive days of the week. For modest weight loss and prevention of weight regain, the goals are slightly different. So adults should aim for a minimum of 250 minutes per week of moderate intensity activities, or 150 minutes per week of rigorous activities, or a equivalent combination of both. And again, that combination can be spread throughout a week, and it can also include muscle strengthening activities, right? Such as resistance or flexibility, again, and generally preferred to be across 2 non-consecutive days during the week. So let's do a quick review of what I mean by moderate intensity exercise versus rigorous activity versus muscle and strength training activities. So moderate intensity activities can include brisk walking, 2.5 miles per hour, dancing, gardening, biking slower than 10 miles per hour. Vigorous activities can include, running, swimming, aerobic dance, yard work, heavy yard work, and cycling 10 miles per hour or faster. And muscle strengthening or resistance training can involve, lifting weights, using resistance bands, doing push-ups, sit-ups, squats, climbing stairs. So it's important to remember also that you can increase the amount and the intensity of the exercise gradually, okay? So it doesn't need to start at these time intervals that we've discussed. You can start slowly and start slowly with the intensity as well. So now that we've gone over some of the activity and exercise changes that we can make, let's discuss some of the pharmacological therapies that we have for weight management in patients with PCOS. For patients that are living with PCOS and living with obesity, and patients that are living without PCOS and living with obesity, the pharmacological management is the same. So how do we identify individuals living with obesity? Okay. And what I mean by the pharmacological management is the same. I'm specifically referring to weight management treatments for overweight and obesity. Okay. So how do we identify individuals living with obesity? So the CDC uses body mass index, or BMI, which is a person's weight in kilograms divided by the square of their height in meters to measure obesity. So BMI greater than 25 is characterized as overweight, and BMI greater than 30 is categorized as obese. So BMI is a population tool to estimate risk, right? And it can be used as the initial tool to screen for obesity. However, it certainly has limitations, and in many capacities can be considered as a oversimplified tool. So BMI does not have the ability to distinguish weight associated with muscle versus fat. It does not have the ability to distinguish body fat distribution, which we know is a known determinant of metabolic risk, right? So remember, measuring fat distribution can help identify higher risk individuals, right? Because increased visceral fat predicts the development of metabolic syndrome, type 2 diabetes, cardiovascular risk. The other thing to keep in mind is that BMI does not account for age, sex, ethnic variations as well. So in June of 2023, the AMA actually released a statement about the limitations of BMI and suggested to use BMI in conjunction with other measures of risk, such as measuring body composition, waist circumference, visceral fat, and considering genetic and metabolic factors. It also stated that BMI should not be the sole criteria to deny appropriate insurance reimbursements. So you're probably wondering why we still use BMI. Well, in the clinical world, BMI is easy to obtain in a doctor's office, and many clinics may not be equipped with DEXA scan machines, in-body scans, and they may often not be covered by insurance and can also be a financial burden to many patients. Besides clinical ease to obtain BMI, many medical cutoffs, including medical and surgical cutoffs, are determined by BMI. Clinical studies often use BMI, and anti-obesity medication indications for weight management also use it. So what we're hoping for is that with this new AMA policy, that it'll start to open up some avenues of access for different pharmacological therapies such as AOMs or anti-obesity medications to individuals who will meet the criteria for treatment based off of other measures of living with obesity. And it's going to be more inclusive towards differences across different ages, sex, gender, ethnicities. So currently, guidelines recommend that individuals who have attempted lifestyle improvement and modification and continue to have a BMI greater than 30 or a BMI greater than 27 with a weight-related or obesity-related comorbidity are eligible for weight management treatment. So with the field of obesity medicine growing and expanding, let's review some of the pharmacotherapy that we've had in the past decade up until now. So in 2012, phentermine and topiramate came out in a combination pill as Qsymia. In 2014, bupropion and naltrexone came out in a combination pill called Contrave. In December 2014, we had the liraglutide 3.0 or Saxenda, which was approved for weight management. In 2019, we had Plenity come out. In 2021, we had semaglutide 2.4 come out. And in 2023, we had tirzepatide or Zepbound, which was approved for weight management. So let's talk about a few of the medical therapies, and we'll focus on a few of them for the duration of this short lecture. Okay, so liraglutide 3.0 or Saxenda came out in December of 2014 for adults living with obesity, and it also has efficacy in adolescents as well, ages 12 and up. So it is a GLP-1 receptor agonist, right? So it activates the GLP-1 receptor and it slows down the stomach. I'm going to repeat that. So liraglutide 3.0 is a GLP-1 analog that activates the GLP-1 receptor. It slows down the emptying of the stomach, it leads to a decreased appetite, and it promotes a feeling of fullness or satiety, and it also acts on insulin levels. So side effects of this medication can include GI side effects, most commonly being nausea, vomiting, constipation, diarrhea. And initial dosing starts at 0.6 milligrams once daily, and that duration can last for a week, and then the dose can be increased at weekly intervals to 1.2, 1.8, 2.4, and 3 milligrams. Contraindications to this medication are used during pregnancy and individuals with a personal or family history of medullary thyroid cancer or MEN2, which is associated with medullary thyroid cancer. So the next medication we're going to speak about is semaglutide 2.4 or Wegovy, which came out in 2021. So Wegovy or semaglutide 2.4 is used in conjunction with lifestyle modifications. So nutrition and increased physical activity, and it's FDA approved for adults with a BMI greater than 30 or a BMI greater than 27 with a weight-related comorbidity. It's also a GLP-1 receptor agonist, so it also slows down the emptying of the stomach, reduces hunger, and regulates insulin levels. So it's a weekly subcutaneous injection. Their doses are 0.25 milligrams q weekly, and after a 4-week interval, it can be increased to 0.5, and then every 4-week interval, you can continue going up. So the doses are 0.25, 0.5, 1 milligram, 1.7 milligrams, and 2.4 milligrams is the maximum dose. Semaglutide 2.4 Wegovy also has a contraindication for individuals who may have a personal or family history of medullary thyroid cancer or MEN2 syndrome. And this is because in preclinical studies in rodents, there was an association seen with medullary thyroid cancer. Semaglutide 2.4 also should be discontinued at least 2 months prior to conception and should not be used in women who are pregnant. So another medication that we're going to speak about is tirzepatide or Zepbound, right? And this is a GLP-GIP receptor agonist. So what is GIP? So GIP is a glucose-dependent insulinotropic polypeptide, and it's also an intestinal hormone that has a broad range of physiological actions. So together in combination, this medication also slows down the emptying of the stomach. It leads to decreased appetite. It promotes satiety and a feeling of fullness, and it acts on insulin and glucagon levels. So the side effect profile is actually very similar to GLP-1 receptor agonists, and it includes nausea, vomiting, constipation, and diarrhea. Dosing the starting dose is 2.5 milligrams, and this can be increased after a 4-week interval if individuals are tolerating it, to 5 milligrams, then 7.5, 10 milligrams, and the maximum dose is 15 milligrams. Contraindications for this medication also include medullary thyroid cancer history, either personal or family, MEN2 syndrome, and pregnancy. So now that we've talked about some of the pharmacotherapy focused on weight management in individuals with PCOS, I just want to add that there is other pharmacotherapy that's used in the treatment of PCOS itself, such as birth control, metformin, and spironolactone. For today, we just focused on some of the weight management specific treatments that we can use in individuals with PCOS. So coming back to treatments for weight management, we've talked about lifestyle modifications, we've talked about different pharmacotherapies. So let's now touch base upon metabolic surgery. So BMI cutoffs for metabolic surgery eligibility were lowered by the American Society for Metabolic and Bariatric Surgery in 2022 to a BMI greater than 35 or a BMI greater than 30 with weight-related comorbidities. So these are the new cutoffs that we have. So hopefully in this lecture today, you've learned about some of the signs and symptoms of PCOS and the diagnostic criteria you can discuss with your doctor. We also know that PCOS is complicated, it's chronic, and we do not fully understand the pathophysiology. However, we do have an idea about some of the associated conditions with PCOS, including those that can contribute to metabolic disease and weight gain, such as insulin resistance. We also know that even modest weight loss in patients, such as 5%, living with obesity and PCOS is associated with an improvement in their phenotypic profile of PCOS. So that means improvement in dysmetabolic features, hyperandrogenic features, and reproductive features. And remember, we have lifestyle changes we can use in conjunction with effective pharmacotherapy or surgical therapy as needed. So it's really important to remember to focus on slow and gradual changes, because this will lead to a greater chance of not only weight loss and weight maintenance, but reversing or halting the progression of metabolic abnormalities and disease states. So make sure that every step of the way you speak to your doctor about any questions that you have. And I want to thank you again for attending this short lecture. But until next time, this is Dr. J.
The OAC has a variety of educational opportunities for you throughout the year, but one of the best places you can turn to for quality, unbiased education is our resource library. Simply visit obesityaction.org/library to check out our brochures, articles, guides, videos, and more health talks. Also be sure to subscribe to our YouTube channel to get notified about any future educational events. Thanks for joining us.